Hey everyone, welcome to the Mettle podcast. My name is Eric Norman. I'm a physical therapist, and shortly I'll be joined by Christian Jorns, who's also a part of the Mettle podcast and is a physical therapist. Today, we're going to be talking about a ACL clinical practice guideline for post-operative ACL rehab. And so we're going to talk about a lot of really cool things. That's kind of the most up-to-date research on what to do, what not to do, and especially talking about returning to sport, returning to running, and what we're looking for, all that fun stuff. So it's a little bit of a lengthier one. Christian and I had a lot of fun diving into it. Hope you enjoy listening to it. And as always, if you have any questions or anything else you want us to talk about or things you want help with, whatever it is, please feel free to reach out. Thanks for listening. Have a good day. Hey, Christian, how's it going?
Hey, morning, Eric. Things are great, except today I'm going to be attempting to move a new wood stove that is 400 pounds and more, perhaps, and that's going to be an absolute bear. And so I was wondering if you had a guess on how many discs I was going to herniate today. I was thinking thinking probably 2.
All five. Just say goodbye to it. This is what you've been training for, Christian, with your deadlifts and your squats. And
this is why I
don't know if you
deadlift.
do carries or not, but this is what we've been training for.
Yeah.
There we go. Yep.
Today, put up or shut up.
Yep. I'm good, dude. Yeah, I'm
How are
good.
you?
It's really weird in my house right now because all my cupboards don't have doors on them. I'm currently sanding, and then next week will be priming and painting. So starting some kitchen renovation stuff, and it's weird as hell to walk into your kitchen and everything is just open. I feel kind of violated, like you can see in all my cupboards. I don't like it.
Yeah, it's brutal. We had that set up for it might have been 2 or 3 months. It took so freaking long. I did all the things you said. And then also once you paint them, we did a paint sprayer, but then you still have little spots. And so you got to go through with super fine grit paper and sand the shit out of that. And then you mess up, so you got to do it over again.
I appreciate
all I'm saying
it.
is good luck.
Yep, I know. It's a motivational piece to see that, and you're like, man, I want to get this job done as quick as possible. But so yeah, that's what I'll be doing once we get off the call. After this, I'll be sanding all my day away. But
yeah. So you're gonna tear your rotator cuff. And I'm gonna herniate my discs.
Not only my rotator cuff, but I have a power sander or like a orbital sander. I'm probably going to get some carpal tunnel soon too. So tennis elbow.
Tennis elbow.
We're screwed. We're done for, man. Well, we were kind of talking before that this one might be a little bit of a doozy. So let's kind of jump into it here. If you want to kind of get us started, Christian, with what we're going to talk about today.
Yeah. So today we're talking about the most up-to-date clinical practice guidelines that we have for ACL reconstruction rehab. And so I just wanted to set the stage a little bit about why these sorts of things are important. So ACL surgery is, in my opinion, a huge deal. Even if you do a pretty good job rehabbing, after surgery, only about 80% of people return to some level of sport. 65% of people return to their pre-injury level. So like you played high school sports, you're going back to high school sports, for example. And then only 55% return to competitive level sports. These are like those higher level athletes, college, professional, that kind of thing. So not great numbers there. But then also, even if you do a great rehab, the risk of an ACL re-rupture or tearing your other side, and not just the ACL, but also like you get a meniscus tear, things like that, that risk is 20 to 25% depending on what studies you read. So like I said, this thing's a huge deal. It's really, really important that we try to do our very best with these people. And I don't really think a lot of patients hear that stuff when they're thinking about surgery. And so, like, in my view, if you want the best chance of success, you really got to do all this kind of work and just work your butt off.
No, I think that was well said. And just kind of going off that a little bit, I feel like sometimes patients, for some reason, and this is no knock on patients at all, but we do have this idea around surgery, at least here in the United States, that like surgery is the magic bullet that's going to fix everything. And it's like, I'm getting surgery. I'm going to be fine. I know like I'll have to put in the work, but things will come around, etc. And just based off our experience, we know that that's not always the case, unfortunately. But just those stats you put out there, Christian, that just shows like, yeah, you gotta put in the time and the effort, and your therapist has to really employ a lot of these up-to-date strategies just to try and give us the best shot at having a successful rehab and successful surgery.
Yeah, definitely.
All right. So anyways, kind of the frame for today is we're just going to take this thing section by section. And so one of the first things that this article really dives into is timing and structure of rehabilitation. And so first thing is timing. And they talk about preoperative rehab versus just like standard rehabilitation. And, we'll see this through a lot of this report, is that they have kind of lower grades of evidence because it's a CPG. We've talked about this before. They have different grades, A, B, C, D. And a lot of these have kind of like D level, C level evidence, unfortunately, but it's still recommended with some of these things. So we'll try and tease that stuff out. But anyways, preoperative rehab shows that there's some things that can be improved, especially like early post-op knee flexion and extension range of motion, which I personally think like that's what, if we can get that range of motion back as soon as possible, you're going to set yourself up for long-term success, months down the road. And so even if we have a little bit of evidence to show that preoperative rehab can be successful with that, I think that's definitely something that would be great if we could do it for all of our patients, which I know can't do it for everyone. But yeah, I am a fan of pre-op rehab. I think that this supports it. But what are your thoughts on that, Christian?
Obviously, we're a bit biased that we want people to come see us before surgery to make sure that they're as good as they can be. But overall, my recommendation is the same, where if you're really struggling with that swelling or that range of motion or just that quad shutdown and that weakness, I do think a little bit of prehab work is important just to see if it helps you at all. And it doesn't need to be a lot. I don't mean like 3 times a week in the clinic up until your surgery for many weeks. I mean, maybe come in once or twice, just learn a handful of things that you have to get done, and then you just go and do those. And I think that stuff is really useful, but I wouldn't say that stuff's worth going bankrupt over. I would save the bulk of your money if you had to worry about that stuff for the actual rehab process.
Totally agree. I think like even just like hey, I'm getting ACL surgery in 3 weeks. Perfect. Come in for one visit. Let's look at what you're having troubles with right now, because we know that preoperative status can definitely affect postoperative results, especially in like the early phases. And so if we can get the range of motion better going in, it's probably going to be better going out. And so, and similar with some other measurements there, but no, I totally agree. One thing that I thought was interesting, and maybe you'll have a different take on this, Christian, but unsupervised versus supervised rehab. And it discusses here, it says that there's no difference between the unsupervised and the supervised program for knee laxity, subjective function, functional outcome, strength, and muscle atrophy. And it actually gives it a C level, so a little bit better than a D level with some of those things. I definitely think that there's a lot of good that patients can do on their own at home, but I think still continuing with what we do, which is a supervised rehab program, it allows us to adjust for any uncertainties or any curveballs that knee or surgery might throw at us, right? If we need to adjust stuff or if we need to work on something a little bit differently, whatever it might be. What is your takeaway or your thoughts on the unsupervised versus supervised rehab?
I've read a couple of these studies over the last several years, and I was really surprised by that finding too. But it's something that I have been actually employing for the last couple of years, where I tend to start with patients more frequently, like ideally twice a week for the first handful of weeks, maybe the first 1 to 3 months, just to get them started, get that range of motion, get that swelling down, get the quad going, all that introductory stuff, create their initial exercise plan. But once they start to feel pretty good and they've hit those major milestones for those kinds of things, and they feel like they can do most of the stuff on their own, I'm a huge fan of them going off on their own. And I'll usually see them in 2 to 4 week intervals where I'll check in with them maybe a month later. We'll review their stuff, do some updated testing, progress their exercises, be like, hey, okay, these are the movements I want you to progress to. This is the sets, the reps, the intensity, all this kind of stuff. So I like to flesh out those programs, kind of like working with a training client in longer time intervals over time, assuming that they're doing well and they're okay with that. And then also, I don't know how insurance works in Minnesota, but in Maine, you get people that have these surgeries and they can only come to PT for 20 visits. And it's like, all right, I really do not want to go through all those visits in the first 2 months. Like, we have a long journey ahead of us, so we need to space these out.
Yeah, that's a good point too, to bring up the insurance piece. Yeah, I would say here in Minnesota is kind of hit and miss depending on what type of insurance someone has, but it's not unheard of to get that, after any type of surgery, or in this case, an ACL surgery. But yeah, that's very, very good point. That not a lot of people take into consideration sometimes, is the insurance coverage piece.
Well, just because it's not supervised, like if you're doing this thing on your own, does not mean that it's not personalized. I am creating a personalized plan for you that you're just going to do without me watching.
Yeah, and it is, and kind of to your point too, it is a, it's a little bit of this independent rehab program that's personalized, but it's at a point where it's very safe in their journey, right? Like, it's not like they're 3 weeks out and you're telling them like, hey, when you feel like your quad function's good enough, you can start doing some more dynamic weight bearing stuff, and here's some different things you could do. And then you're like, all right, figure it out in the next 4 weeks. It's very much like you said, they've met these milestones. They're safe to do this stuff. And it's a personalized program. I totally agree. All right. So next, we're talking about therapeutic modalities. I feel like this one could be spent a good chunk of time on. Right away, the first thing they talk about, continuous passive motion, or a CPM. This is, whenever I think of a CPM, for some reason in my head, I think of like the 1980s. I don't know if you think the same thing, but I just think like old school, it made sense, right? When they get out of surgery, that hook that leg up and just move it constantly back and forth. Makes total sense, but most up-to-date evidence showing that there's really no difference between doing a CPM versus just active range of motion. And I mean, especially like cost-wise, right? If we're thinking about a machine that has to be either covered by insurance or purchased by the patient, it's free to move your leg back and forth on your own. And I would argue even that that's probably more beneficial because you're getting muscle contraction when you're doing so. And it's not just that you're contracting the muscles, but there's a lot of interplay with the nervous system between agonist and antagonist muscles. And for people who don't know, agonist muscles, those are the muscles that create the movement. Antagonist muscles, those are the muscles that kind of would, quote, oppose the movement or do the opposite movement. And so what we see sometimes in post-op, especially ACL, is that individuals have this kind of like fighting or a little bit of a like muscle guarding between the agonist and antagonist muscles. And that's what can make that knee so tight sometimes and not want to move. And so I would even argue that doing active range of motion is going to be better than CPM because you're working on that nervous system relationship between those different muscle groups.
Yeah, I don't have much to add to that other than I did have to use these a lot when I was working my first year of school in a hospital setting that did a lot of joint replacements. We had to put those on everyone that had a total knee replacement for like the first day or two that they were in the hospital. Again, this was 2014, so not quite the 80s, Eric, but I'm still old enough. But they were just like not that great. They weren't that cool then. We thought they were a good idea, like they make sense on paper, but then when you actually figure out, okay, these things are heavy, they're bulky, the patient is lying in bed, you got to strap their leg in, it moves their leg in one singular plane when they might like a little bit of a different path to get there because everyone's anatomy is different. It was just a pain in the ass, and it really wasn't worth it for all the reasons that you said.
So let's go on to the next one. Boy, the next one, cryotherapy. I mean, kind of a hot topic, but I feel like when it comes to post-op ACL, we shouldn't have to argue much. Should we ice or should we not ice? What are your thoughts on that, Christian?
I think it's a hot topic for people who care way too much about things that don't really matter. It's just like not that important. So the guidelines say it has some use very early post-operatively to help your pain. And I am totally pro icing as much as you feel like is helpful for a handful of days, week or two. And that's just because like it's not really going to slow down your healing process a whole lot. And what's more important for the healing process anyways? to me, it's getting sleep. If people have so much pain they can't sleep and ice takes the edge off so they can actually get some damn sleep, well, that's what I want them to do, because I need them to sleep as much as they can every night for the first many, many months.
Yeah, I totally agree. That's actually one of the things that I highlighted in my notes for this podcast today was that there's good evidence to show that early on it reduces the intake of pain medication. And it's like, I mean, that alone should be like, yeah, ice it. Like you said, sometimes we make a bigger deal out of things than what we should. So, all right. So that didn't take very long. I'm glad that actually went pretty well. Yes. So we're in agreement. Ice the knee. If you have an ACL surgery and you're 3 days post-op and someone tells you that you shouldn't ice it because you're going to inhibit the healing process and that inflammation is necessary and all this other stuff, please just go ahead and ice the knee if you want to ice the knee. That's simple. Okay. Next. NMES, neuromuscular electrical stimulation. I actually just bought one of these units for home. Funny enough. Christian, what the heck is NMES and why would we use it in the clinic?
NMES is where you take pads, you put them on the target muscle, let's say your quad in this example, and then you hook those pads up to a machine that puts electricity through it. And what that does is it turns your muscles on without you actually trying to fire them. And this sort of therapy has been around for a super long time. We have a ton of research on it. And the take from the research article is that it is quite helpful and we should be doing it. And I listened to that for sure. And it's not just this article. It's also like I said, decades of research has shown that NMES is an effective treatment. And I think that we should be doing it. And actually it was just not too long ago, it might have been 6 months or so, listening to an E3 rehab podcast where those folks interviewed a couple NMES researchers for this exact diagnosis for ACL reconstruction. And they said that they highly recommend using NMES up until people have 80% limb symmetry. So what that means is that if you assume that your non-operative leg is 100%, you're going to use NMES on your quad in this example until that quad has 80% of the strength of your non-operative side. And so that like takes a long time for a lot of people. That's usually like 3 to 6 months, I'd say, for the average person. So we used to use this for maybe just the first month or two, if that. But now I personally use it until they hit those 80% marks, as long as they don't mind coming into the clinic that long. Yeah. So I'm very pro NMES.
I wasn't aware that I should give that podcast you're talking about a listen to. I would say I'm also in favor of it. Just full disclosure, I like it. I think it's good. I agree. There's a lot of research behind it that shows that it's good. I usually stop once, probably around that 12-week mark, 10-week mark. Like once the patient is showing like good weight bearing control, they have good quad function, like they're walking well, etc. Once we can start to progress their weight-bearing activities more and isolate that quadricep in some different types of exercises, that's when I tend to back off on the NMES usage. Now, I'll have patients that have access to NMES at home or in the training room or whatever it is, and I'll tell them, like we'll be 16 weeks out, and it's like, yep, like go do your thing, go do the 10 whatever minutes of NMES in the training room and, get that quad working. But when they come to the clinic, I tend to allocate more of that time to more of the weight bearing stuff, if we're starting some like return to, plyometrics or whatever it is. That was before you mentioned this podcast I should probably take a listen to, because 80% limb symmetry is, like you said, that can take a little bit longer than just those 12 weeks. Yeah.
Yeah, but I think that's up for debate. Clearly, this clinical practice guideline did not include that recommendation, so it's hard to say if that's actually the truth or that much more beneficial. But I think, like you said, using it somewhere between what you're saying and then what those recommendations of 80% limb symmetry are, I think you really can't go wrong with that.
Agreed.
Bottom line, highly recommend. I definitely use in the clinic, and I think people should be doing this during the rehab process, because no matter how good your surgery goes, no matter how strong you are preoperatively, how good you feel, your quad is going to be shut down. There is a concept called arthrogenic inhibition, where when there's a bunch of trauma around the knee, in the joint. It makes the local muscles just not function as well. Your body just like doesn't want them to exert as much force as they normally would as a protective mechanism. And NMES can help overcome
Mm-hmm.
that sooner than not using
Right.
NMES. And it's important because you want your quad to function so you don't like fall on stairs, and so you can reach your strength milestones, so you can like run,
Right.
so you can start
Yeah.
doing agility,
Yeah.
all that stuff.
Yeah. Maybe it'd be a good thing to highlight why it's important to have good quad strength, because that's what a lot of this article is about. Yeah,
That'll
that's a
come up
good point.
later too.
And then also something else they talked about with NMES was that it seemed to show some benefit like early on in rehab when it come to like joint swelling too. And so getting some of that, yeah,
I did not know that, but
that's
that
what
was interesting to me.
same. I'm trying to wrap my head around the theory or how the mechanism would work in the knee. That like if you shock a muscle group around the knee, how that's gonna influence like effusion in the joint or it's like liquid in the joint. I don't know. But I guess, we just take their orders and follow it blindly with what they say when it comes to NMES. But yeah, so anyways, the next thing that they talk about here, electromyographic biofeedback. I'm gonna be honest with you, I don't really use that a whole lot in the clinic, really for anything. I don't know if I'm speaking blasphemy on this, but what about you, Christian? Do you use electromyographic biofeedback at all?
No, there are people, and like I think I have a coworker who uses it a lot. But you have people that are really really into it. They think it's super valuable, and patients that like it. I think
Yeah.
that's great. I don't think it's a bad thing to do. This evidence says it's like, maybe do it if you want to, but I guess you and I are
Yeah.
heretics.
Yeah.
We don't want to do it. It's just like it takes time. It takes such a long time to get this stuff set up and to coach it, and I would rather be
Hmm.
using that time for other things. And that was probably going to lead us very
Yes.
nicely into blood flow restriction
Yep.
therapy.
Low load blood flow restriction training. BFR, as it goes by, in other words. So BFR, what the heck is that? This is the modality that you'll see people with like blood pressure cuffs around their limbs if it's like up on the bicep or on the upper thigh. In this case, it'd be on the upper thigh, where you do these low loaded exercises. So it could be like non-resisted knee extensions or like mini squats or, it could be anything where you're doing these minimally resisted exercises. And what happens is it restricts the blood flow anywhere from like 80 to 100%, um, throughout the leg. And so what happens is you get this pooling effect of the blood flow in the muscle belly. In this case, let's just focus on the quad. And why that's important is it's sending basically a chemical signal to the muscle to say that you did a lot more work than what you actually did, right? So you can do, I mean, I might be way off with this analogy, but I'm dramatizing it for the podcast. So you could do like, let's say 50 knee extensions with no weight at 80% blood flow restriction. Now, if you did that without any blood flow restriction, that's just, another day sitting in the chair. It's not going to do a whole lot probably. But with blood flow restriction, because it pooled the blood and now it's getting more of a chemical reaction to it, your body or that local muscle thinks, holy crap, we just did like 95% one rep max. Let's metabolize and have what's called an anabolic process, which is building up the tissue. And so it's a way of kind of trying to like trick the body into thinking it did a lot more than what it actually did. And in my opinion, and what shows in the research article, can be very useful both prehab, if someone has a torn ACL and they want to do it prehab, but also post-op once they're ready for it.
Yeah, I think that was a great explanation. It's just, where do you fit it in? It's not way more beneficial than any other type of strength training that we do. It really isn't more beneficial at all, to be clear. And it takes time to set up.
Mm-hmm.
It's actually quite painful for the patient often because it just burns like hell. And it takes a long time to go through the whole process. So it's like, okay, for that same 30 minutes of time I have with this patient in person, I could be doing other things like checking in with how they're doing mentally. How's the home exercise program going? What's your range of motion like? Should we work on that? Let's coach your gait pattern. Let's coach your stairs. Let's do NMES. Let's all this other stuff. And so it's like, where do you fit BFR in? The window for where it's most effective is in the earliest phases of the rehab where I'm also busy working on so many other things. And then just given the constraints of the clinic and the insurance situation, all that, it just falls by the wayside because it's just not that important to me. And I almost never do it, but that's my personal opinion. Maybe it's a hot take for some people, but that's just it's a pragmatic
when
approach,
people listen to this episode 2 years from now, you better watch out. No, I agree though. Sometimes I'll go into that visit being like, hey, BFR might not be a bad idea today. And then next thing I know, we only have 5 minutes left. And I'm like, well, guess we're not doing BFR today. Just because it does take a lot of time to set up. And when I kind of order my visits in terms of what I want to do, it's usually lower on it. But with that being said, I do think that, especially with athletes, because it's weird to say, but because it burns like hell. And to be honest with you, when I first did BFR, I asked the person who put it on me, I'm like, is this thing on right? Because this thing fucking hurts. Like my leg doesn't feel good. And it's like, nope, that's how it's supposed to be. But I feel like, especially athletes, they like that early on because they're like, they're like, hell yeah, I feel like I'm doing something right now. So it's a little bit of a mental thing too, I think, especially for the athletes. But I totally agree with what you're saying. It's very uncomfortable. It's time consuming, and there's just other things, especially, if this is best implemented early on, there's a lot of other things early on. So
Yep, totally agree.
All right. So anyways, yeah, kinesio tape. That's the next one. I can honestly say I haven't put kinesio tape on a post-op ACL. What about you?
No, never once. But I will say the article says it may have some use early post-operatively to help swelling, but we don't really know for sure. And it's like I always say about tape, the research isn't great. If you like it, do it. It's not harmful. And if you feel like it's helpful, I totally support you. I'll tape you if you want when you're in the clinic. It's just like, do you want me to spend 10 minutes taping you or do something else? It's just up to you how you want to spend your time and money.
I agree.
I'm just not a huge advocate.
I'm in the same boat as you. I mean, I have colleagues that do it and their patients get better, and awesome. I'm, great for them. But like it says at the end here, kinesio tape is low cost and there are no reported adverse events. So yeah, doesn't cost a lot and you're not going to hurt anything. So if you want to give it a try, give it a try.
You didn't finish that sentence though. However, the available evidence suggests any therapeutic effect of its use is likely small
You're
to
right. I left that part out. I'm trying to give the kinesio taping individuals a chance here, Christian. Yeah. So anyways.
They've had their chance for decades. It's not doing it.
Fair enough. So yeah, I don't know if there's a whole lot to talk about kinesio tape, just because, like we said, there's not a whole lot of evidence to really back it up. Oh man, yeah. Let's move on to the next one. I've been kind of dreading talking about this one, dry needling. So this one's
all you.
The article doesn't do it very well. At the end of the article, they give kind of a summarization, like a nice little picture for us therapists that don't like to read a whole lot on what to do and what not to do. And dry needling has a big old red X by it. I think my take on this is, first off, when we do dry needling, I might have mentioned this before, but we have to wait 6 weeks until we can do any dry needling in the body after surgery, because we want to make sure we're not going to put the patient at risk for something like an infection. And then we have to wait 12 weeks to do any dry needling around the knee joint. So I didn't actually look at the study in specific. Oh, I see. Okay. It says right here, if I just read a little bit more, 7 to 21 days. So 1 to 3 weeks post-op, right? So early on is when they're doing this. I think that there's better time being spent with other stuff early on. I also think that doing it later in the rehab process is much more beneficial, because it gives the joint a little bit of time just to frickin' settle down. If you just get out of a major surgery and then you're going to go stick more needles into someone, the body's like, what the hell are you doing to me? Let me just rest. How about that? How about we don't have to stick needles into me yet? But I have found patients, especially in their calf, individuals that might be non-weight bearing, if they have a meniscus repair on top of it or something. I found that individuals later on can have a lot of issue with like that calf just being really tight. And sticking a couple of needles into that calf, giving it a little bit of electrical stim, it just, at least like anecdotally, patients do really well with that. They really like it. They feel like, again, it's a mental thing. They go to therapy, they get needles stuck in them, and they tend to feel better after. Like, hey, great, I'm making progress and this is good. But just overall, I see with pre and post range of motion, a lot of times that calf or even the quad might be really tight, and kind of, patients describe it as like pinching when we're trying to push that like end range flexion sometimes. And we'll do some range of motion before, and it'll be maybe like 123 degrees to neutral, right? But at that end of 123, it's really pinching. And then we'll do some dry needling to like that calf or maybe some to the quads and take it again. And a lot of times I see that range of motion go up to like 128, 129. And patients are like, oh, this doesn't pinch anymore. And then they get up and walk on it and they're like, oh, this feels a lot better. And so we can argue about the theory behind dry needling and what it actually does, but basically the rule of thumb is that dry needling kind of like, quote, resets the muscle. That's like the phrase used for that. And so think about a lot of these muscles around the knee joint probably aren't moving the way they normally are used to moving for, heck, 3 months, 4 months by the time we're dry needling. And so the idea is we're just trying to bring a little bit of like homeostasis into that environment. Like, all right, reel it back in, bring the muscles back to baseline. Let's try and get this thing reset. So again, early on, I agree. I wouldn't even do it based on the restrictions of, the 6 to 12 week time frame that I talked about. But I think dry needling has been really beneficial for my patients after 12 weeks. And we don't even do it a lot. It's just maybe 1, 2, 3 sessions. And then after that, they usually feel good enough. We don't have to get back to it. Anyways, that's my take on dry needling. I think it's good. I know the study says not to do it early on, which I agree. I wouldn't do it then, but I would like to see studies like post 12 weeks, kind of like measuring things like range of motion, just subjective pain, etc. Because I think it's beneficial.
Yeah, and even if you don't want to dry needle, I do massage.
Yeah.
People have tight calves, tight hamstrings, tight glutes because they're walking funny or haven't walked in a while, and their body's getting used to it again. People get sore all over, not just their surgical knee. So like I will spend 10 minutes massaging their calf, and if they get back up off the table and they're like, wow, that feels so much better, let's go exercise. Great, that's a win for me.
Yeah,
so
absolutely.
I'll do
and
that
I think
instead.
we talked about this our last podcast too, Christian, about how manual therapy is it's an umbrella term that holds many different things underneath it. Soft tissue massage and dry needling are two of those things underneath this umbrella of manual therapy that that can be used. And so, like you said, if someone doesn't like needles, just get in there and do some massage to it. That tends to make things feel better too. I don't know how much time you want to spend on this one, just because I don't do it. I don't think you do it, but whole body vibration, I've never even seen it done.
No, I didn't even know what it was. I feel really ignorant for not knowing what it was, but I looked it up, looked at the machines. Between the research and then the price of the machines, there's a reason I don't do it. I'm not going to ask my boss to spend 10 grand on a vibration machine that has like minimal research on it at this time for how effective it is. So it's not there for me. But over time, hey, maybe it'll be something we add.
So the next one, we're talking about kind of the big hitter now. Finally, we get to it. Exercise and exercise initiation. Okay, so I think one of the big things that stuck out to me right away when we're talking about exercise and exercise initiation is early mobilization shows to be pretty freaking good. If that's walking, weight bearing, active range of motion, kind of you can classify it different ways, but early mobilization shows good improvement without compromising the knee laxity regardless of the graft type.
Yeah, definitely. I will make a distinction between mobilization and weight bearing. Mobilization means just move the damn thing. You should be moving that thing immediately after surgery. That's just super important. And then if you're cleared to walk on it, like let's say you have a pure ACL reconstruction with no meniscus repair, you're often cleared to weight bear as much as you feel comfortable in those first handful of days. Go ahead and do it. But I'm going to say this thing for range of motion, for weight bearing, for exercise. You're really just trying to do as much as you can handle. without increasing your pain, your stiffness, or your swelling. If you're increasing any of those, it's a pretty strong indicator that you're doing more than your knee likes right now, and you should just back off, especially with the weight bearing and the exercise, but at least keep up with the range of motion work. Those are usually not super aggravating for your pain, stiffness, or swelling.
No, absolutely. I agree. And I think it's good to mention those guidelines too. I say it for every, even like non-operative stuff, right? If someone just like has an ankle sprain or something, it's like pain, swelling, lacking range of motion. Those are kind of the biggies. Weakness. If you notice any of those things coming on, just to reiterate what you said, like probably doing a little bit too much. Might want to back off a little bit. But it's very likely that we're not physically damaging it. It's just the body's telling you, hey, this is just a little bit too much right now. But anyway, going on from that, Christian, I sent you a video of me talking to my computer's AI system. And I asked the AI, is it, and I can't say its name, otherwise it's going to come on, but I was like, can we do open kinetic chain, which for people that don't know, that's when the foot isn't planted. All right. It's in open space. Can we do open kinetic chain knee extensions early on in ACL rehab? AI came back to me and said something like, probably not safe to do, puts a lot of pressure on the knee, puts a lot of pressure on the grafts, can damage things, etc. You're better to do things like quad sets and straight leg raises. So, setting the floor for you, Christian, is it okay to do open chain knee extensions early on in ACL rehab?
Yes, and the Aspetar clinical practice guidelines that we're talking about now would also say yes, and decades of research would say yes. And I'm just very reassured that AI is not going to take my job anytime soon.
There we go.
So we're good to go. But yeah, what I will say though about open chain quad extensions, in particular, it's those. The controversy around them is that people once thought, and a lot of people still do think, that if you do them too soon, you put undue stress on your ACL graft that's been reconstructed and you could damage it. That's just like not true. So I'm not going to even elaborate more on that. It's just not true. So the guideline or the recommendation we have, though, is that we don't do them before 4 weeks post-op. And the reason for that is the best research that we have showing that they're really safe to do didn't start doing them until 4 weeks post-op. And so we don't really have a ton of evidence before that saying that they're safe to do. I have read, I think, 2 studies that said that they are totally safe to do from day 1. People were doing them full range of motion too, day 1, and there was 0 change in laxity or pain or anything like that over time. And so based on those studies, you probably could do them before 4 weeks, but I personally wait till 4 weeks just to be extra safe because I just don't want to put my license on the line, and I'd like to have as much research supporting what I do as possible in case anything would ever happen.
Totally agree. Unfortunately, so as physical therapists, just so people know, we can't, like, if your surgeon or your physician's assistant is like, hey, we don't want you doing open chain knee extensions for like, I don't know, let's just say 12 weeks. Maybe some of us has been told we don't want you doing open chain until at least 12 weeks. And you come to me or Christian, or at least me, and you're like, hey, I really want to start doing knee extensions. And then I say, well, surgeon so-and-so doesn't want you doing it for another 4 weeks. I'm not going to go rogue and go against the surgeon, because I like surgeons to not hate me or get mad at me. But I do try and have conversations and say, hey, this is what's, going on in the research. But I agree with what you're saying. As long as I'm cleared from surgery to be able to do it, I like to try and get that knee movement open chain as quick as we can. And the research here talks about starting at a 90 to 45. The reason why, let's just get into a little bit, because it's a lever arm issue, right? I didn't want to know how in depth we wanted to go on this, but if we think about the leg at 90 right here, there's really no stress being put on that knee joint. And then the further out you kick to neutral, now that bigger lever arm is theoretically putting more stress on that knee joint and on the ACL graft. And that's kind of why they think like, we don't want to do open chain because we're putting too much stress on it. We know that's not the case. But even in this article, it mentions just doing it from here to here, which now that is putting frickin' minimal, if any, again, on that knee or on that ACL graft. And so to be even extra safe, we don't even go 0 to 90. This article says to go from 90 to 45 after 4 weeks.
I do that too. I'll usually start to 45 the first handful of days, and then I'll go to 30. And I usually just stop at 30. And there is some measurable tension on the ACL after about 45 or 30 degrees, whatever, towards full extension. It's not a huge deal, but again, I'm not going to risk it. But also, if you're thinking about this like from a strength and conditioning standpoint, the conversation around lengthened partials is pretty big right now. And so when you're doing it from 90 to 45, you're effectively doing lengthened partials. And we know that doing those has a really good hypertrophy stimulus to the muscle. So it's like any way you slice it, we're really, really safe when we do these. And it's quite beneficial for a quad stimulus. So very
Same
pro,
here.
everything
Same
about
here.
it.
Well, let's move on next. And next thing I got on here is eccentric. And so eccentric strengthening versus concentric strengthening, or also isometric strengthening. These are just all different types of muscle contractions. But the idea with eccentric is that it is a heavier stress on the muscle, right? So eccentric is a contraction of lengthening, controlled lengthening of that muscle. And what we know based off of research is that eccentric contractions are going to apply higher loads or higher forces. And you can load it more and whatnot if you're weightlifting. And so that can apply a bigger stress to the muscle, and that can give us a bigger response in terms of a metabolic or anabolic response. And so what the research article says is that it should be done along with concentric strengthening. Eccentric overloading did not enhance quadricep strength gains, though eccentric can improve things such as functional outcomes and psychological readiness to return to sport. I really like those last two. I totally agree. When we look at things like a jump squat, or we look at things like step ups and step downs, right? Without even knowing it, we do eccentric contractions all day, every day. And if you only train concentric or isometric post ACL, and then you're missing a large part of that muscle control and that muscle strength, which is eccentric. And so, although I'm a little surprised that the research article says that eccentric overload did not enhance quadricep strength gains, I would have put my money on the opposite. But I do totally agree that, functionally and psychologically, super important to do eccentrics when they're ready for it.
Yeah, do it all. I try to get isometrics early on, especially just because they tend to be less stressful and they also tend to be better for pain control. And then I try to go the full isotonic, so eccentric and concentric at the same time whenever I can. If I can't, like let's say someone is just starting learning how to single leg squat down to a chair again. They may not be able to stand up from the chair, but they sure as heck can control their way down. And that's the eccentric. And if they can do that and do more reps of that, that's just a stepping stone to them getting really strong. Kind of like when you can't do a pull-up, but you can jump up and then lower yourself down. It's the exact same thing. It's a way for you to get stronger, and we're just going to use all the ways at our disposal to get you where you want to be.
Yeah,
responsibly
absolutely.
Over time, of course.
Yep, I agree. All right, so then after that, they go on and discuss things like motor control and motor control training. Motor control it's kind of just like a fancy word of basically, or a fancy term of how the kind of the nervous system and the muscles interact together around that joint, and how well you can not just control, but, perform and kind of like muscle memorize said movement. At least that's how I kind of look at motor control, motor learning. Cause it's a nervous system type response, right? We know that in individuals that have a lot of pain, that their brain will change, and that certain body part will become more prominent within the brain because it's more painful, right? Kind of similar thing after surgery. If you have someone post ACL and they're not able to, they haven't jumped in, I don't know, let's just say 6 months because of the injury, and then after surgery, by this time they haven't done a jump in 6 months, that motor control pathway from the central nervous system down to that local muscle group, and not only that one muscle group, but every other muscle group around the knee, and the coordination of it all, yeah, that's going to take some training to get back. And so motor training, motor control showed good improvement, short and intermediate term, in proprioceptive capabilities of the joint, even up to the 2-year mark. So in terms of motor control, motor training, definitely good to do.
Yeah, totally agree. Examples of this are going to be simple balance exercises, standing with your feet in front of each other, standing on one foot, closing your eyes while you do it, standing on foam pads, Bosu balls. Anything that involves controlling your body in space, kind of dynamically or statically, often using an unstable surface, has some benefit. And this is one of those things that I do a lot in clinic, especially once they're in the later phases of their strength plan, because most people can do the strength stuff on their own at home or at the gym, and I don't need to see you squat for the 10,000th time. Like, you're good there, okay? But maybe I'm going to help you work on some balance drills or some dual task drills where you're doing a balance task plus counting backwards or saying your favorite animals, things like that. Just like things to challenge your brain while you're challenging your balance, because that type of motor control, motor learning stuff is really useful and tends to work better when you're working with a partner.
There you go.
So I'm that partner in the clinic.
I'll be your partner. I could see you in the gym watching someone squat. You're just standing there, just straight face, just trying to find any inadequacies of what they're doing. The classic, just arms folded.
Yeah. At some point, you're just done coaching the squat, and I don't need to see you do it anymore.
Go do it on your own.
And it's also like, what are you paying for? Like, you're not paying me to watch you squat. You're paying me to get you better. And motor control type stuff is
absolutely.
part of that.
There is a section here on plyometric and agility training. I mean, part of me wants to save that for when we start to talk about like return to sport, because I think that kind of fits better there. But we are kind of coming up to the end here. I mean, there's a section on core stability training, and it's like, yeah, do it. Train your core. That's a good idea. Train your upper body. Train everything, you know? It's a nice thing about the leg is that you got 2 arms and a core and another leg you can keep working on while the other one's healing up. That's kind of my take on it. And then they also talk about aquatic therapy, which they say, yep, that's good to do once the surgical site is healed, so we don't have any chance for infection. Aquatic therapy is also beneficial to do. And do you have anything else to add on exercise there, Christian, and any other takeaways from this part of the article?
No, I think that'll come up once we get to more of those milestones.
Well, let's jump into that. If you want to kick us off talking about things like return to running, return to sport, and kind of where you want to start on that.
Yeah, sure. I'll start spitballing there. So in rehab, we have done a lot of research on trying to figure out what needs to happen for you to be as safe as you can be when you want to get back to whatever you want to do. And so this stuff is up for debate, but generally all PTs agree that certain criteria should be met. One of those things we mentioned earlier was strength symmetry. So how strong is your surgical side compared to your non-surgical side? And we use percentages. So 70%, we want to see that you hit 70% in your quad and your hamstring before you begin to run. This article says 70 to 80 or even closer to 80 if possible, and that's great. So more the better, but I'll start getting people going at 70%. You want to hit an 80% symmetry for return to some kind of agility work. You want to hit 90% for return to sport drills. That might be your agility stuff plus a soccer ball, for example. Doing some drills on the field with your team, but not actually scrimmaging or playing a game. And then you want to hit 95 to 100% for full return to sport. So that's just strength symmetry. We use that as a proxy. We also do a simple functional test called the single leg squat test, where you stand on a high box, like a 12-inch box on the side, and you do a sideways squat, also called a Peterson squat. And we do that side to side, few reps each, and we just compare the overall shape that your body's making. If you look great, you pass. If you look like crap, well, we got to work on some stuff. So that one's really useful. We also use a couple questionnaires, some on just like the general feeling of your knee, but one that I like a lot is it's called the ACL Return to Sport After Injury Survey. It's just like it's a feels questionnaire. It's like, how confident are you in your knee? Like just like a bunch of questions around how you feel about your leg. And we want to see that you hit about 90% score on that test. So you feel super, super confident in your leg. It's for us to feel more confident that you're going to have a lower risk of injury. And then we also do a bunch of hop tests. There's a hop test battery called the Fowler-Kennedy hop test, and you got to hit a symmetry there. So they typically involve hopping for distance. And so the distance that you hop from side to side should be about 90% on that surgical side compared to your non-surgical side for return to sport. And then we also think about you in general time frames. This used to be how we only thought about you, and I guess some clinicians probably still do, and I hope they stop that. But time is important too. So for returning to running, we have research to say that you should not run before 8 weeks post-op. So somewhere in the 8 to 16 weeks is a good time for you to be running, assuming you hit those other milestones that are important for running. And I personally aim for 12 weeks as a good benchmark. I don't really like to go before that. Just, I don't know. That's more of a feeling than it is evidence-based. And then for agility or plyometrics, that tends to be around that 4 to 6 month post-op mark. And I aim for at least 4, not before that. And then 6 to 9 months for return to sport. So 6 months is the earliest that we would really ever recommend. And that's really just for the most exceptional people. And I've never cleared anyone personally before 6 months, but I have had a couple people, one just recently that I probably could have. I just I'm not too keen on that. And the reason for that is there is a famous study that looked at injury risk from 6 to 9 months post-op, and there was a large injury risk reduction every month after 6 months up until 9 months where that benefit dropped off. And so that's why we tend to prefer to wait for 9 months post-op. So 9 months seems like that sweet spot. And if you wait any longer than that, it's still beneficial, but the degree to which it's beneficial is much smaller. So it's hard to hold someone back for that long. And I guess the last thing we look at, or at least I care about, is just like your general movement quality. So when you squat, when you walk, when you run, when you jump, when you cut, like, do you look okay? Do you just like visually inspecting? Do you look a little lopsided? Do you run like a troll? Like these kinds of things. I want to make sure you look good. And so you put all that stuff together and then we figure out the timing for return to running and plyometrics and sport and all that stuff.
Hey, is that something you put down on your objective report? Runs like troll. Oh, guess they're not ready to return to sport yet. Still running like a troll.
No, but I do get made fun of in the clinic sometimes because in my notes I'll sometimes say this person is profoundly weak. And yeah, that one
I like it.
I should probably
I like it. I think you
tone
should
down that language.
I think you should keep doing it. I like that. I'm gonna start using that. Profoundly weak. But no, yeah, I agree with everything you're saying. Obviously, I mean it's based in research, right? It's things that we know from years of research and what we should be doing. And yeah, I think, even in PT school, I remember we were even kind of taught like timeline, of like 6 months do this, 9 months do this, 12 months do this. And it's like now, especially with this clinical practice guideline, I love how much more it is just criteria based. Not everyone's the same. Some people might meet the criteria at 9 months. Some people might meet the criteria at 7 months. Some people might, heck, they need maybe more than 9 months, And it also depends on what you're trying to get back to. If you're just a weekend warrior that's, you don't got anything going on in the wintertime and 12 months is December and you're just waiting for spring, it's like, yeah, just keep training that sucker and get it ready for spring when you want to get back to your, weekend activities. And then, it's not as much of a rush to get back versus your collegiate athlete or high school athlete or whoever it is that's like, hey, I got sports season starting at month 8 and I don't want to miss a single game. And it's like, all right, well, let's get after this thing then, try and get you back at, month 8. So yeah, it kind of depends on the patient too and what their goals are and what they're trying to get back to. And yeah, no, I agree on the whole, like, how are they moving? I remember one of my more recent ACL athletes that I was training, they were about 7 months out and we were working on more like position specific drills. And I remember we were in the gym training it and I just had a moment where I was just like, holy shit, you look like a football player right now. Like, just like how you're moving, you just look like a football player again, And usually the athlete knows that too. Like, for the first several months, they're like, I just don't feel the same. And then, usually around that 6, 7, 8 months, it kind of clicks for them. And they're like, I actually start to feel like I'm, back to where I was before. So I definitely take that stuff into consideration too. Because if the athlete's saying, or the patient is saying, I just don't feel comfortable with whatever the activity is, then we're not going to force them to do it, right? we want to build up that confidence level of the patient as well, which I actually think kind of part of that questionnaire that you're talking about, one of them, the study suggests is the Tampa scale of kinesiophobia. And that one is, basically like how confident are you in these different movements and are you afraid to move in any way? If the patient is afraid to move, probably not going to give them the all clear. We want to build up that confidence in how they feel. So everything else that you talked about there, Christian, totally agree. Looking for the different limb symmetries, obviously things like range of motion, swelling, mechanics, functional tests, all that different stuff, making sure that it's all looking good. Well, that kind of rounds out the research article in terms of where we started early on with rehab and now, kind of wrapping up the return to sport, return to play, return to activity and whatnot. My biggest takeaway for this article in total is what we talked about early on, which is the first several weeks, probably like up to 3 months of rehab post ACL. As a therapist, I want to see you 1 to 2 times, 2 times a week, because there's things that each surgery can be a little bit different on, patient specific, and we need to kind of calculate that stuff in to what we're doing. But yeah, once we get to, 12, 16, 24 weeks, and then it's more of a 1 to 2 times a month check-in of like, let's evaluate how the jump's going. Let's evaluate how the running's going. Let's evaluate how these numbers in the gym are going and how do we have to modify that. And then slowly ramp up that training over time. But patients, athletes can be very independent with this stuff with check-ins once or twice a month as it goes on. And so for anyone listening to this that has an ACL or rehab or is, just curious about it, that's my biggest takeaway is keep working with the therapist until we've reached those benchmarks. Even if, let's say you're 6 months post-op and you only see me once a month, if there's something that you want to tweak or change, I still encourage my patients, be like, hey, just check in, send me a message, give me a call, be like, hey, how does this sound? Do you think I could start doing this? And then a lot of times you don't even need to come into the clinic. I can just be over the phone and say, yeah, I think that's totally reasonable. Start adding that in. Or, you know what? Let's hold off a little bit until we know you can do this, and then we can start doing that. So I think that continuum of care is important to know, and that it's going to look different for every patient, but in general, early on, we want that very frequent interaction, and then as they get further out, we can be much less frequent in how much we see the patient.